Okay, hi guys. Sorry, do you mind if I get started? So sooner we start, probably sooner we'll get to go home. So I'm Shruti. I'm a third year. I'm at the Alfred this year. Yeah, I'm pretty nervous. I'm not gonna lie. And if you have any questions throughout this lecture, let me know. Pelvic anatomy is obviously not one of the most scintillizing topics, so it might get a bit dry from time to time, and I will be asking some questions along the way. If you've had a flick through the slides, you'll know this. Yeah, but if nobody answers, I'm not one to judge. I'm never one who answers questions in lectures, so that's A-okay. Alrighty, let's get started. So what we're going to cover and the order, wow, cool. Hey! Okay, what we're going to do is we're going to start off with a quick look through bones and muscles, and the biggest thing probably with pelvic anatomy is that the questions you're going to get asked on this are generally going to be more clinical based. So yeah, we'll just bones, muscles and things are good to understand, and then as you understand them better, you'll get to understand the clinical things better. So that's what we're going to do with this. So yeah, let's start off with bones. This is a book from a picture from Morandeli. And I put it in here because I actually think I made the mistake in my first and second year of trying to go through the textbooks and learn all these words, which now I've totally forgotten. But I think the way to go is actually by learning some of the pictures and being able to visualize things in your head, so that when it comes to questions and things, you can picture things better. So this picture I put up for this red line and the green line. So the red line, as it says, is the pelvic inlet. Pelvic inlet is made at the front of it, as you can see, is the pubic symphysis. At the back is the sacrum, and the thing in between is called the linea terminalis. And the pelvic outlet is the green line, and it's at the bottom of the pubis. So the pubic arch is that little archy bit. Then you've got the pubic rami, and the back of it is that tip of the coccyx. And does anyone know what is between the inlet and outlet? What's that space called? Clue. It's either the greater or lesser pelvis. Yeah, awesome. Whoever said lesser, cheers. Yeah, so that's the lesser pelvis. And the greater pelvis is also called the false pelvis, and that is above your pelvic inlet. And it's actually part of the abdomen, but it's just tucked in here. So this is just what I said before, so you can have a look at this later. The second bit of the bones that you probably need to know, or just be kind of familiar with, is this pelvic girdle. And just a note that's kind of interesting, you always see the pelvis in pictures being kind of with the pubic symphysis here and then all in one straight line kind of thing. But in your body, it's really tilted forwards. So the aces, which is, oh, I don't think I have a pointer. Do I have a mouse? That'll do. The aces, so here, is in line with your aces and the pubic symphysis. So this bit, when it's joint with the other bit, and this bit up here are actually on the same plane, so it's tilted that much. Okay. These are your the three bones, the ilium, ischium, pubis. I don't want to waste time going through those because they're not very examinable, and I guess know where you're, in clinical examination, I guess, know that, when you do your hip examination, you feel for, the ACIS, you feel for the PSIS, and you feel for, the greater trochanter, that's probably as much as you really need to know about this kind of stuff. Oh, I guess also some of the tuberosities, ischial tuberosity, ischial spine, but we'll get to what's important a little later on. Male versus female pelvic girdle, I would recommend learning this one. I've just got a nice little table. I just put in an empty slide so that if you're flicking through these later and want to test yourself, you can just look at the slide, see how much you can remember, and then flick to the slide and then fill it out kind of thing. Okay? So yeah, the basics, the crux of it really is that for males, it's thicker, heavier, deeper, and narrower. And there's apparently the reason for this is because females obviously have to have babies, woo. So we need to have a wider pelvis so that the baby can come out. Whereas for dudes, I guess in history they were made to run away and hunt and stuff like that. So it was actually better for them to have a narrow pelvis. Yeah, I know, it's kind of sexist and blah, blah, blah. But yeah, so it's better for them to have a narrow pelvis, which helps them run faster and stuff like that. And yeah, this angle business, less than 70 for males, wider than 80 for females, small things like that, just keep in mind. Next slides. Oh, I should have also said I've changed the slides a tiny bit because I had a bit of a freak out last time. I was like, ah. So yeah, this one's a bit different. Yeah, so pelvic shapes and diameters. This was something that got mentioned in one of my anatomy tutes last year, and I never really got it, so I thought I finally got it, so I thought I'd share it with you guys. So you've got these like 4 diameters. And the one that's important for babies, conveniently, is called obstetric conjugate, which is, I guess, obstetrics is like the whole baby thing. So yeah, that makes sense. And it is like the obstetric and your transverse diameter are the 2 kind of like sideways ones. So if you're looking at like the pelvic inlet, I'll use the proper words, they're the ones that go sideways. And then your anterior posterior, sure enough, goes like anterior to posterior, and diagonal goes diagonal. And the reason why this obstetric conjugate is really an important diameter to know for like gynae and stuff is because when it comes to delivering babies, that's the shortest distance that the baby's head has to get through. So if it's too small, that mother is going to have a hard time getting the kid out. And they can't actually measure this obstetric diameter directly. So they take actually the diagonal one, and which they can measure, and then subtract 1.5 to 2 centimeters. Oh, and don't bother typing furiously. I will send these to Kelvin as soon as the lecture is over. So yeah, and this was just, again, changed a little bit so you can see the diameters. I don't know what I had before. I think I was just nervous and chucked in random pictures. Sorry about that. And then just like a picture of which way the kid's head goes when it comes out. Yep. All right, ligaments. There's a lot of ligaments, and the great news is that they're not actually that hard, and you don't really have to rote learn anything because they're fairly self-explanatory. Like take sacrotuberous ligament, so it goes from the sacrum to a tubercle somewhere. So like, yeah, that's not that bad. Sacrospinous, like it goes from the ischial spine to the sacrum again, tuberous. Yeah, cool. This is a good picture. I like this one a lot because it shows you where your greater sciatic foramen is and where your lesser sciatic foramen is, and where, like, what divides them. So the 2 important ligaments that probably you do need to remember are those sacrotuberous and sacrospinous ligaments. So the sacrospinous ligament is the one that really kind of divides your greater sciatic foramen from your lesser sciatic foramen. Yeah, and fun fact is, like, have you heard about the coccygeus muscle? I can never picture what any of these things were, but now finally doing this lecture, I'm like, oh, there you go. Well, that actually goes, like, pretty much along this ligament. So the coccygeus is, like, if you're trying to picture where it is, it's along there. Yep. And important foramens, so you've got your greater and lesser that I've talked about, and your obturator foramen, which is in the obturator canal, which isn't that, like, obturator bit. Yep. Cool. Okay, these slides are good, and I would recommend learning them. Obturator canal, fairly obvious what goes through that one. Obturator nerve, artery, and vein. Very handy. Like, sometimes anatomy is great because it's just like, you don't have to think too hard. Like, yeah, it's fairly self-explanatory. The greater sciatic foramen. This is a nice little mnemonic that Jimmy actually taught me, and I like it a lot. Pins. So this is for the contents. That's another really important thing I should have mentioned above. The greater sciatic foramen, there's a really important landmark, is this muscle called the piriformis, and that kind of divides this greater sciatic foramen into an upper and lower bit. And the reason why I tell you this, friends, is because we got this awful question when we were in Year 2, and it wasn't a multi-choice question, it was a written question, which was like, what is the muscle that divides? And then the next questions were like, what are the contents of the bits above this muscle and below the muscle? So that was not a fun question. So ever since I've been like, learn this. You never know when it's going to come up. I'll just quickly read through them. So posterior cutaneous femoral nerve, inferior gluteal nerve, nerve to the quadratus femoris, pudendal nerve, internal pudendal vessels, nerve to obturator internus, and sciatic nerve. And then your lesser sciatic foramen also has a handy mnemonic, PINT. So you got your pudendal nerve, internal pudendal vessels, nerve to obturator internus, and tendon of your obturator internus. Internus, yeah, cool. it took me a while to get this into my head, and probably some of you have already grasped this concept, but for those of you who don't quite understand what the difference is between the midpoint of the inguinal canal and the mid-inguinal point, I think the best way of thinking about it is like midpoint of the inguinal ligament is an easy one to start with because it's just literally the midpoint of that ligament. And as you can see in this picture, the ligament kind of comes to here. Whoops, I clicked. To there. And so it's going to be kind of like the midpoint of that ligament is going to be more lateral to the mid-inguinal point, which is between your acis and the pubic symphysis. Does that make sense? So the midpoint of the inguinal ligament is more lateral than the mid-inguinal point. And I'll show you, oh, here we go, it's right here. Navel is a nice way of remembering the order in which the important structures sit in this place. So as it says here, your femoral nerve goes at the midpoint of the inguinal ligament, and at the mid-inguinal point, you've got your femoral artery. And navel stands for nerve, artery, vein, empty space, and lymphatics. And that's kind of the order that they sit in the femoral canal. Does that make sense? I should probably, am I going really fast? Is that okay? No? All good? I'm just kind of going through this a bit quicker because I feel like the more important stuff is the clinical things, which will be useful hopefully not just in your exams, but next year as well. Triangles. Sometimes anatomy has these weird triangles that might come up in various things. So the femoral triangle, this is probably more lower limb, but I thought I'd chuck it in because why not? So the borders of this are your inguinal ligament, your sartorius and adductor longus, and Hasselbalch's triangle. The borders of this, so Hasselbalch's is the one that sits like above, kind of like with the rectus abdominis, the like inguinal ligament, and your inferior epigastric vessels. I think I've got a better picture of that down below. And this is a good important note down here. So indirect hernias are generally lateral to these, I'll show you in the picture, it makes a lot more sense. Here we go. So here is the picture, excuse the fuzziness. So with hernias, have you guys been taught about hernias at all? Kind of, yeah, a little bit? Okay, cool. It makes sense because when you've got two types of inguinal hernias, one's called direct and one's called indirect. So generally a hernia is anything that pushes through the wall that's containing it. So that's what a direct hernia is. It pushes through the wall inside this Hasselbalch's triangle. So it's pushing through that muscle. Whereas, yeah, the indirect hernia is kind of sneaky. It just like tucks into this inguinal canal and it can cause problems when it gets stuck in there and whatever is in the hernia gets like caught up and strangulated in there. Yeah, so therefore, as you can see, the direct, so just so you know, this is your midline. Oh, you can't see that. Yeah, this is the midline of your body. So your rectus, your abs. Yeah. And this is your ligament. And these are your inferior epigastric vessels. So as you can see, the indirect hernia is going to be more lateral to the direct hernia. That make sense? Yeah, a couple of nods? Okay, cool. And this is a table from Morandeli again that, I don't know, I was told by someone to learn. I could never quite memorize it. I don't know, it's just a lot of words. But if that's helpful, it's in there for you. Yeah, we'll move on. Okay, first question, woo! A man is going, okay, by the way, disclaimer, these are all maybe from like past exam questions that I've seen. And the answers aren't necessarily in the slides that I've made. So I've kind of put in questions that complement the stuff that I've got information on so you can learn from the questions and the slides differently. All right? So a man is undergoing a hernia or a happy, yeah, I have no idea how to say that. And it says fixing his hernia, accessing the inguinal canal. Which of the following is false? Anybody want to give it a whirl? Did someone say C? I think someone did say C. Well, C, I believe, is the right answer, so I'll just check. Yeah, I think C is the right answer. Yeah, oh no, it's B, my bad. Sorry, the floor is the conjoint tendon. And I think the answer to that is, oh yeah, sorry, my bad. Yeah, it's in this. This is why the table is kind of useful. Occasionally you'll get a random question like that, so it's just good to know that the floor is never the conjoint tendon. But yeah, it's a tricky question. Inguinal canal. Important things to note, that's all on the table. In females, it's pretty simple. You've just got this round ligament of the uterus and your ilioinguinal nerve. In males, you have the spermatic cord and also the ilioinguinal nerve. And the spermatic cord, they say it's got this like rule of threes or whatever, which just means you've got like 3 arteries, 3 fascial layers, 3 nerves, 3 others. Like, dudes, you guys are complicated. Females are really nice and simple. So you have 3 arteries: testicular, cremasteric, and artery of the vas deferens, fascial layers, external spermatic, cremasteric, and internal spermatic. Nerves are the ones there, and 3 other things. Yep. Is that all right? Okay, and this was just the thing on hernias that I said before, so I'm not going to dwell on this too much, except to add that I put in these femoral hernias as well. So femoral hernias are less common than inguinal hernias in general, but they're more common in females than males, whereas like the inguinal hernias are more common in males in general. Yeah, which is just fun. Well, good to know in like clinical practice if you have a dude who comes to you with this hernia that's like in his scrotum, and you're like, I wonder, is that like, it's probably not a femoral hernia, even though it's like really far down. Because, I should probably say, femoral hernias, the kind of landmark is generally as to where they come from. Inguinal hernias are generally above the inguinal canal. Femoral hernias come from below the inguinal canal. Cool? Alrighty. Another picture about that. So like I said, I've kind of focused more on the clinical things because I think that's what like most of your questions from now onwards, probably till the end of med, will be more clinical based, so I think this will be more useful. And this is useful to know for indirect hernias, so the ones that go through your inguinal canal, because in normal, it's called a processus vaginalis. I don't know if you've heard it mentioned, but now you have. And it's this little thing here, and when you're like a fetus, it's patent, so it's this, it's like a tube, and it leads to the your scrotum, basically. But what's supposed to happen is that it's supposed to seal itself up. But in some people, it doesn't. And in these people, if they get an indirect hernia, that's when you like see it in the scrotum because it's like fallen down this patent processus vaginalis, and it's like in their scrotum. So that like contents of their bowel are in their scrotum. It's kind of gross. And this, for some weird reason, was in the pelvic chapter of Morandeli, so I chucked it in there in case. Another thing that I never really understood in second year was all this like spondylitis, spondylolisthesis, and all the rest of it. So the first thing to understand is where is your pars interarticularis. So the way I remember this is like articularis. It's like your facet joints, they're the articular joints. So the interarticularis is the bit that's between your facet joints. So like in this picture here, that's your pars interarticularis. And the difference between spondylolysis and spondylolisthesis is that, so spondylolysis is what they talk about, that Scotty dog thing. Have you guys done back yet? I should probably ask this first. Yeah, okay, last semester. Yeah, cool, yeah, good. Okay, so spondylolysis is, just a break. So you see this like collar, which is the fracture of the Scotty dog, and spondylolisthesis is when actually the bit that's on top of that break like slides forwards. So the poor people have this like, it's really unpleasant. They get like spinal cord compression because they've got like the actual vertebrae moving forwards. So you got displacement. So the longer one means it's worse, basically. That's another way to remember it. All right, muscles in the pelvic cavity. We're doing great, I think. Yeah, cool. So this is your pelvic cavity. I think the most important thing to remember is like your pelvic floor is all muscular. The walls are kind of like the bones, posterior wall as well. And like in childbirth, like the one clinical thing, when the kid's coming out, often those muscles and the ligaments can be injured because obviously you're pushing this thing out. And as a result, pregnant women, if there's a question asking you what kind of incontinence they're most likely to get, the answer is like urinary stress incontinence. And that's the one where like if you cough, you pee without meaning to. And the other type of incontinence, does anyone know what that is? It's coming up later on. Urge, urge incontinence. And that's the one where it's like, it's a problem with the nerves, so you feel like you constantly need to go pee, even though you've got no like pee in your bladder. Alrighty. Muscles, there's just a quick little table with the ones that are in Morandeli, and a bit about their origin, insertion, innervation, and action. I won't go through that. The pelvic floor, they're called your levator ani muscles, puborectalis, pubococcygeus, iliococcygeus, and urococcygeus. And they form what's called your puborectal sling, which just means that they kind of like hold the rectum and kind of help you hold in the poo. So it's just like an extra thing so that you don't have like fecal incontinence and you're not just pooing all the time. Yeah, nice to know. This is a great topic. Yeah, okay. So these are just the muscles, the pictures of them. So your piriformis, and see, this is what I mean by the coccygeus is pretty much exactly where that sacrotuberous ligament is. Like it goes from the tubercle to the sacrum, just like the ligament. So handy. Piriformis, coccygeus, and the levator ani muscles. Another question. You're at a rural GP placement and a mother of 5 children presents with total fecal incontinence, urge incontinence. So this time she's got urge incontinence, don't know why. So maybe that's even a typo, but I'm not sure. What is the most likely structure that's affected? So here it's not so important what incontinence she has, but if she's completely incontinent from her backside, what is most likely to be injured? This is a tough question, and to be honest, I disagreed with the answer that the previous person put. And I've got my justification in here because obviously, if you disagree with me, that's okay. Just feel free to flick me a message to let me know why. Does anyone want to venture a guess? Maybe. All right, I might just it's easier this way. I actually think the answer is A, and simply because it says total fecal incontinence. And while the previous person thought the answer was C, puborectalis, actually the two things that hold your poo in are your external and internal anal sphincter. And it turns out, I did a bit of research, that the external anal sphincter is more linked to urge incontinence. The internal one is more linked to overflow incontinence, or like the stress incontinence and stuff. And puborectalis, ischiococcygeuses, and iliococcygeus, they're kind of like, they help keep in the poo, but they're not really the primary mechanism by which, if they fail, you're not going to be totally incontinent. That was my justification. If you disagree with me, I won't hold that against you. Yeah, in fact, if you do, I'd be really interested to know what you think. All right, pouches. Has Professor McNennan done the thing where he gets like a couple of volunteers to stand up with like a sheet and one of you's like the ovaries? No? Am I just... Oh. Yeah? Okay, good. It would be embarrassing if he hasn't. So this is good to know. These pictures probably actually help explain it a lot better. So in females, the thing to note is like the 3 big kind of organs that you have in order from like anterior to posterior are your bladder, your uterus, and then your rectum. So you're going to have a pouch between the bladder and the uterus, and then another pouch between the uterus and the rectum. So I was going to ask you which is the one that's a Douglas, but the recto-uterine pouch, the one that's between rectum and uterus, is the deepest pouch. And the reason why that's important is because if you have a lot of if you're standing up and you're a person who's got a lot of extra fluid in your body, that's where it like deposits. And you actually see that quite a bit in hospitals, like people who have all this fluid everywhere. And like if they want to drain it, it's best for them to drain it from this pouch of Douglas, because obviously if you drain it from up here, you're not going to get all of the fluid. Yeah, and the other one is called, again, it's really easy names, like vesico-uterine pouch. Sorry, my pronunciation is probably gross. Because vesico, anything that's got like vesico in it is generally bladder. Yep. Males, simpler, you just have bladder and rectum. So you only have one pouch, and it's called your rectovesicular pouch, vesical pouch. Cool. And this picture, it's kind of gross as well, but it's from Morandeli. The main reason I put it in was just to show you kind of where the differences between your abdomen and then like pelvic structures, and also to show you that there's kind of 2 different types of fascial layers. One of them is called parietal, and one of them is called peritoneal. So the parietal fascia is the stuff that covers your muscles, and the peritoneal fascia covers like the organs, which is why like it's the blue line that's covering kind of the abdominal cavity where all your organs are. It's covering your cervix, covering your bladder in males. Yeah, that's the main purpose of this picture. If it helps, that's great. If it doesn't, and if it's like too much stuff, that's fine too. Neurovasculature, woo, we're moving, good speed. Okay, arteries. These may not seem useful, but actually this has been one of the most useful things from Pelvis that I've done this year. That and hernias and probably other stuff too. Okay, anyway. So the way to learn arteries is to draw them. And this picture in particular was the picture that I used to base my drawings off. And I know it's a gross thing to ask, but try and learn this by drawing it. And then you actually understand where the branches are coming off, and you can visualize it in your head. And if you get asked a random question that would be impossible if you've just like learned all these words, you can actually picture in your head what's the most likely answer. So yeah, draw this out. I guess the biggest thing to note, just to learn, is that your internal iliac artery. First of all, does anyone know, so what level does the common iliac artery bifurcate into the two? L4 or L5? Put up your hand if you think it's L4. It's L4. Cool, thanks. And the veins, so the veins are like a level further down. So they, the external and internal iliac veins join into the common iliac vein at L5, so like a level lower. Alrighty. But the external iliac artery, as you can see, doesn't have a lot of branches, except for this little teeny one called your deep circumflex iliac artery. And it's the one that goes to become your femoral artery, okay? Whereas your internal has this really complicated series of branches, wow, and it doesn't become your femoral artery. Yeah. Cool, and that's just a little thing. And I think this was actually mentioned in one of your lectures, and I thought it was actually really useful. So the external iliac, like I said, becomes the femoral. Internal iliac, there's a little mnemonic-y kind of, what's it called again, where it's like a phrase, I don't know. I love going places in my very own underwear. And the purple is representative of your posterior division of your area, and the green is the anterior division of your internal iliac artery. Cool? I'm not going to read that out because it's just a whole bunch of names, and you won't remember it. Okay, next slide. Veins. Yeah, this is cool. So I really love this picture. I've never seen such a simple picture before, and it shows it really, really well. This is your portal system, so you've probably already covered this with whoever did abdo. But the important thing here is portal system is what basically drains between two organs instead of going from like an organ straight to the heart. So here you have your inferior mesenteric vein, superior mesenteric vein, splenic vein, and then hepatic portal vein. And the way that they kind of draw it is like, it's like a dog. Like the liver is like its head, and its tail is like here, and these are its two legs. Don't know what happened to the other two. And so another clinical thing that they can ask you about as well in questions, in fact, I'm pretty sure I have seen a question on it, is with your testicular veins, one of them goes straight to the IVC, and the other one goes to the renal vein. And this is important because your left testis, if you're a dude, it has an increased chance of collecting fluid because that left renal vein, it kind of like gets squished a little bit by your aorta, because the aorta kind of like sits across it. So that means that there's like this backflow of blood that kind of goes through the renal vein and then back through the left testicular vein. So you get this fluid that can potentially accumulate in your left testes. So if a dude has like enlargement of one of their left testis, you've got to consider that it could be a problem with the aorta, like they could be having an aneurysm, very possible. And that's what's pressing it even more than normal. Cool? Lymph nodes, not my favorite topic, but important, so good to know. I guess like the main ones to know are your external iliac nodes, internal iliac nodes, sacral nodes, and common iliac. So external takes things from superior and anterior parts. Internal takes fluid from deep perineum, and sacral is from the back. So this is like upper and front, deep and back. And they all kind of drain into the common iliac. Cool? There's a picture to help. Okay, I put this is also new, this isn't in your slides. I just remembered that Jimmy taught me how to draw the lumbosacral plexus, and I couldn't do it last year. I tried doing it again and I couldn't do it, so there's a little video that shows you how to draw it if you, for some reason you think it would be useful. The main nerves to learn are pudendal nerve, genitofemoral nerve, sympathetic nerves, and parasympathetic. And of this, it's good to know pudendal S2, 2, 3, 4 keeps the shit off the floor. That's something that someone once told me. Yeah, so that's for like continence, pudendal nerve. Genitofemoral, yeah, the cremasteric muscle, dartos muscle. Yeah, just it's all in there. And the other interesting thing to note is that you've got these like splanchnic nerves, weird name, and all of them are generally sympathetic except for your pelvic splanchnic nerves. It's like you've got thoracic ones, you've got, I don't know what the other ones are, there are other ones. But the only ones that are parasympathetic are the pelvic splanchnic nerves. Cool? Another question. Yeah, so like I said, the answer isn't in the slide above, so sneaky. Okay, so a lady presents with left iliac fossa pain that radiates to the medial thigh, aspect of the thigh. It's found that she has an ovarian carcinoma of the left ovary. Which nerve supplies pain in the medial thigh? Yeah, obturator, I heard someone say. Very good. So is it C or D? Yeah, it's C. Woohoo, well done. Nice job. Okay. Yeah, so it's just something you've got to learn. Another question. The preganglionic sympathetic fibers from T5 to 2. This is a really mean question. I put in the meanest questions I could find because I figured like if you can deal with the meanest questions, then the other ones should be all right. T5 to T12 into the abdomen via which means? Yeah, and just preganglionic sympathetic fibers, T5 to T12. Anyone want to venture any guesses? Is it all right if I just go to the answer? Okay, cool. And I've just got a little like reasons for each. So vagus nerve is mostly parasympathetic. It's like the one that does most of your parasympathetic stuff. Phrenic nerve is just remember that like C3, 4, 5 keeps the diaphragm alive, so it's not T5 to T12, so it's nowhere near right. Esophageal plexus is also like, when we're talking about the pelvis and ovaries here, not your esophagus, so too high. Sympathetic trunk, it has mostly preganglionic fibers from T1 and to L2, L3, so like it does kind of cover it, but it's a lot broader. It's not very specific to T5 to T12. So the actual answer is, oh, sorry, I lie. It's superior to T1 and inferior to L2 and L3. My bad. That's why it's not the sympathetic trunk, because it actually like skips that bit in between, the T5 to T12. And that is where your thoracic splanchnic nerves come in. So yeah, that is the answer. And I just put it there, what I said before. So all the splanchnic nerve groups are all sympathetic except for your pelvic splanchnic nerves, which are parasympathetic. Oh, and just like preganglionic just means like before, there's like a little ganglion where all the cell bodies go and then there's another nerve. Yep, so that's the preganglionic and the ones before that little ganglion. Okay, we're moving on to actual organs now. So ureters. They're about 25 to 30 centimeters long. Probably the most important clinical thing to note is that this thing that they say, water passes under the bridge. So your ureters, are the water, pass underneath your uterine artery. And that's really important when you're doing surgery there because you really, really don't want to like accidentally clamp or like ligate, like cut off your ureter because that kind of makes the whole kidney screw up. That's never good, because your kidneys you only got one of, like, or two of, but once it's, sorry, that was really bad, but like once it's gone, it's gone. Like they can't regenerate, is what I was trying to say, sorry. And the other thing to note about the ureters, that's clinical, and this you can also be very easily asked on, is that the points of obstruction are where it naturally gets thinner, and that's 3 points. You've got your pelvo-ureteric junction, so when it leaves the pelvis of the kidney, the pelvic brim, so yeah, pelvis, and your vesico-ureteric junction, so when it enters the bladder. So when you get stones, those are generally the 3 places that you see a stone. And just a random fun fact that I don't know, I just remembered now, is like when you look at kidneys and this kind of stuff on x-rays, generally you can never actually see the full ureter. Like if you put contrast in, like it'll be like white and then it'll go black for a bit and white again. And that doesn't mean that they have an obstruction. It turns out that because the ureters have their own like contracting movements, so they're contracting all the time. So like obviously in one picture there's going to be a bit of it that's contracting, So who knows if that comes in handy next year, you can sound smart, that's great. Yeah, so it's actually, if you see the full ureter, that makes them suspicious that you have hydronephrosis, or is that what it's called? When you get like really enlarged kidneys full of fluid. Okay, bladder. So I guess the most important thing in the bladder is you've got this trigone of the bladder, where you've got the two ureters coming in, and then the urethra coming out. Oops, sorry, my bad. Yeah, and then there's just innervation for you, and the two sphincters. So the internal one, in general, I've noticed that the internal sphincter is usually like smooth muscle, and the external one is generally like somatic control, so you can like control that one in skeletal muscle. Just general observation. Okay, here we go, next slide. There's a pretty big difference between a male and female urethra, and I've been asked this before in the hospital, so it's good to know. So male ones are obviously much longer and like bendier. Female ones are a lot shorter, so females are a lot more likely to get UTIs, and it's actually, they're so much more likely to get UTIs that if you're a female and you present with a UTI, they often don't give you treatment. If you're a male and present with a UTI, they generally have to give you treatment because it's gone a lot further, and so it's more serious by nature. Like, wow, random, but true. And the male one has like 4 different parts to it. So it's got the like prostatic part where it goes through the prostate, membranous, which is like this tiny little bit, intramural, which is like another bit along here, and then penile urethra. Oh, hang on, which one's the longest one? Intramural. Oh, I have a feeling I've done one of those things wrong. I'm sorry. Might just, because that does not add up to 20. I have a feeling that intramural is the longest. Yeah, intramural is a lot longer than that. I think it's about 15 centimeters, not 0.5 to 1.5. My bad, I'll fix that. Yeah, okay. Female, there's no different regions. Like, it's just this tiny little thing. My bad, sorry. Male and female urethra, just from a different perspective, so you can just see bigger pictures. And I guess in females, it's good to note that the urethra is in front of the vaginal canal, and then you've got the rectum. So, like, females have 3 holes, males just have 2. Okay, cool. Done. Next question. A frontal supine CT shows a calculus stone lodged in the left ureter. Which of the following is true about the anatomical aspects of the pelvic part of the ureter? Mouthful. Yeah, anyone got any answers? Oh, I like this question. It's a good question. Yeah. Anybody got any ideas? Okay, I'm just going to go to the answers. The answer is C. Yeah, so I've heard someone say excellent, good job. So it crosses posterior to the bifurcation of the common iliac artery, so that's just wrong. It's in close relation to the ovarian artery, caused it to be, so it wasn't the ovarian artery, it was the uterine artery. Sneaky. Enters the bladder away from the bladder trigone. Well, that's wrong because 2 of the 3 points of the trigone are the ureters and are the ureters. So yeah, it very much is part of the trigone. So yeah, and it enters the bladder at such an angle that acts as a anti-reflux mechanism. That's just a true fact, and yeah, it's kind of good to know. Rectum, cool. This was actually useful, and there is like the dentate line or the pectineal line. It's called the 2 things. It's actually really important to know what happens above it and what happens below it. And I think in your workbooks you even have like a table or question or something and you have to fill it out, but I've done that for you as well. So it divides the superior 2/3 from the inferior 2/3. And I guess another important point that I think was in some of the words above that I didn't read in one of the previous slides is you have this thing called the pelvic pain line. And generally that is like, the pelvic pain line is like the bottom of the abdomen. So in that picture that was really messy and gross, and there was like the blue line and the green lines, the blue line that was like the bottom of the abdomen, that's where like your pain line is. So that's the difference. Above that pain line, it's all what's called visceral pain, and below it is, what's the other pain called again? Somatic, yeah, somatic pain. So it's like a lot sharper and more localized and stuff like that. Whereas for the rectum, the pain line is at this dentate line, so it's just a bit different. Yeah, so arterial supply, it makes sense, like superior rectal and below is your middle and inferior rectal, and conveniently same thing is for the veins. But the most important thing about the veins is that above the dentate line, you have your portal system drainage. below it, it goes straight to the IVC. So like that's why whenever they talk about like portal hypertension and stuff, you get this backflow of blood and you can get problems above that dentate line, and that's kind of like rectal bleeding and stuff. Like you get varices and rectal prolapse, I mean not prolapse, but bleeding, and it's from above the dentate line. Innervation, autonomic versus somatic, and epithelial is apparently endoderm above and ectoderm below. And lymphatics, oops, yeah, I didn't say those, but yeah, that's it. Cool. Hemorrhoids. All right, yeah, this is the clinical stuff where they might ask you questions, and this is actually useful for next year as well. So, I don't know, even if it doesn't come from your exams, it's worth looking over if you're doing a GI rotation next year. So hemorrhoids, there's kind of three conditions: hemorrhoids, fissures, and fistulas. And if you don't know anything about them, I mean, it's hard to know what the difference is between them. So I'm going to just quickly talk through that. So hemorrhoids are basically from an internal source, and they're kind of like varicose veins in your rectum. And they're caused by that like mucosa in the rectum becoming inflamed, and then the vessels kind of get irritated, and they also become inflamed and varicose-like, all twisted and gross. And the way it presents is you'll get patients come in who've had like bleeding. And when they say bleeding, the important questions to ask in your GI history that you definitely will get extra points on are like, is the blood fresh? Like, is it red? Is it black? Like, what is black blood? What is it typically called? Melena. Yeah, very good. And that's like an upper GI problem. Whereas this will be very red blood. And then it seems like a weird question to ask, but like, is it on the toilet bowl and like on the toilet paper? Because the thing with hemorrhoids is that it generally is blood that's on top of the poo, because it's kind of like you poo and then the blood comes on top of it because it's coming from like that close. Whereas I think from a different, yeah, anyway. But yeah, it's very fresh blood is the basic thing. And it'll be on the toilet paper and in the toilet bowl in your questions if you get it on an MCQ. Internal hemorrhoids come from above the dentate line, so that's generally painless because it's got visceral innervation, so it might just be like a little bit of pain. Prolapse hemorrhoids can like push through the anal canal and you'll get, yeah. And external hemorrhoids are generally hard lumps around the skin. And you generally just treat the symptoms. If there is like thrombosis, so that's veins getting all big and gross, you can incise them and drain them, but a lot of surgeons don't do that. They just treat it symptomatically. Fistulas and fissures. So hemorrhoids is to do with the veins that are lining the rectum. Fistulas and fissures are more to do with like you get cuts at your bum and they like link up. So a fistula, the cut from that's like your bum, will link up to the rectum, like higher up. And they are painful, but not as painful apparently as fissures, which are like little cracks and tears like right at your butt. They don't link up to anything else, but they're apparently excruciatingly painful. And there won't be blood, and like these patients will come in being like, if you want to try a rectal exam on them, they'll be like, no. Like they will not let you touch that area, especially if you're a student. Not that you want to, so it's like, anyways. And for fistulas, it's not as painful, but they've got worse complications because when you have this connecting up of your like rectum and the outside surface, if you like block up that outside surface, you can get all this gross bacteria that's in your like poo accumulating in this random space that's between your rectum and the outside of your skin, and you can get these abscesses form. So the way they actually treat this is by like opening up those fistulas, so reopening that skin and draining it so it allows it to heal properly. Really gross, really painful, I'm sorry, but yeah, it's stuff you should know. And some pictures to just show what the different things are. Okay, we're up to genitalia, woo! So male genitalia. This is just a quick slide that summarizes what each of the main things you have to know about are and what their function is. So I put the function in red and the thing, the anatomy stuff in the other color, black. Yeah, so sperm gain their initial motility and ability to fertilize in the epididymis. I think I've actually got a picture of it in the next slide. No, I don't. I've got, oh, there, I think that's a picture there, yeah, so we'll get to that later. The ductus deferens, so that's the vas deferens, moves the sperm through the, from the epididymis to your ejaculatory duct, which, yeah, okay. And seminal vesicles are these two little things that join on at the very end of the vas, and they secrete like energy, basically, stuff for energy for the sperm, so fructose and other sugars and ascorbic acid. The prostate, which is like what most people know about, it actually produces, again, more nourishment stuff, so citric acid, and it secretes this antigen called PSA, which is really important for benign prostate hyperplasia and prostate cancer. There's a lot of controversy over this thing. And finally, you've got these tiny little things called bulbourethral glands, or like Cowper's glands, they might be called each, which produce at the very end of the whole thing this little pre-ejaculate fluid, which has more basic stuff in it, so it survives in the acidic vagina or whatever when like sperm goes there. All right, this is important because I wanted to also talk about benign prostate hyperplasia, because that's, again, something that I've seen quite a few questions on. And the prostate, even though it's just this tiny little, they call it a walnut-shaped thing, I don't know, they always compare this stuff to food. It's a little bit disconcerting in textbooks. But, okay, the prostate sits here, so just below the bladder, and it's divided up into either zones or lobes. And you could get asked a question of it being about, like, the lobes or the zones. So if they ask a question to do with zones, it's important to note that, like, the zone, when it gets like hypertrophy, that causes the most problems in terms of like continence, is this transitional zone. Cool? Because it's the one that's like right next to the urethra. So it's gonna, if it gets bigger, it's gonna squish the urethra and you're gonna have continence problems. If they're talking about lobes, the lobe that's closest to the urethra is this median lobe. Okay? Cool. So that's the one. So the things that cause problem when they get enlarged, the transitional zone and the median lobe. Yeah, those are just pictures that help you hopefully maybe visualize where things are. And this was just more to explain the slide above, so I probably should have done it in the opposite order, but that's all right. Yeah, and here's my slide on benign prostatic hyperplasia. This is just if you guys have already done a urinary systems review. I'm not sure if you have yet, but if not, this is a nice little mnemonic to, I don't know if it's nice, but pussycats, to remember your symptoms, systematic review questions. Sorry, I'm not used to talking so much. So pain, and with pain, you've got to ask 3 questions. Like, do they have like flank pain? So that's like your loin to groin pain. Suprapubic pain, that's like bladder problems, or like pain while they're peeing, so dysuria. And the ones that are bolded are the ones that you have problems with if you have BPH. So urgency, you've got poor stream, you might have like a bit of incontinence with like overflow incontinence, and you're probably peeing more regularly because only a tiny bit can get out at a time, so you've constantly got this pretty full bladder. You want to do a PR exam in a person who you suspect has BPH because you can often feel the prostate, and yeah, we've had to do practice ones this year on like dummies and stuff, and like it's so weird. But yeah, you can actually feel quite a lot. Like you can feel how many nodules are there, and all, like yeah, and you're expected to. And PSA, like I said, is an antigen that is produced by the prostate. But the reason why, like some people, they used to use it, like if you had a really high PSA, they'd be like, oh my God, you've got benign prostate hyperplasia, or you might have cancer. But actually, it turns out that you can have an elevated PSA from cancer, BPH, yes, prostatitis, so inflammation, bicycle riding, like somebody could just be a keen biker and have a high PSA and they don't have cancer. From doing a PR exam, which you've probably just done, recent ejaculation, so like, it's like this PSA antigen doesn't actually tell you a lot about whether or not they have cancer. But what it is useful for is like monitoring a person's progress. So if they come in one time with like a really low PSA and they come in the next time, they haven't been bicycle riding, they haven't had a recent ejaculation, and they've got like a PSA that's like through the roof, you can be like, ooh, suspicious, let's do more investigating. So yeah, that's probably what like it'll tend towards. Alrighty. Franklin is a 70-year-old man who was recently diagnosed with prostate cancer. A common problem that occurs is damage to the internal urethral sphincter. How do you explain its function to him? Yeah, okay. Yeah, how do you... Did someone say... Yes, C. I heard a C somewhere and that was correct. So yeah, the internal sphincter helps prevent this retrograde ejaculation. All right, and this one I've already actually told you the answer to, but that's okay. Which lobe of the prostate causes narrowing of prostatic urethra during BPH? Shout it out, somebody. Yeah, B, median lobe, cool. And if they'd asked what zone is it? Yeah, transitional. Awesome, learning. Woo. Other clinically significant stuff. Vasectomy is when they ligate your vas deferens, but it's actually can be reversible, so you can actually have a vasectomy and then they can apparently reconnect it, which I think is amazing, but what else? This is what Morandelli said. So, and the other thing is abscesses in your seminal glands. You can palpate those in a rectal examination as well. So if you have to ever do one, you have to talk about the prostate and whether or not you can feel these little seminal glands. Females. There's, I think, people doing repro physiology next week, so I haven't gotten on about the period cycle and things like that, menstruation cycle rather. So your ovaries, again, they use foods. They say they're almond-shaped. And then your uterine tubes, or your fallopian tubes, there's again 4 parts to that. So you've got the infundibulum, which is at the end, and it has these little finger-like projections they call fimbriae, which are really close to the ovary. Then you've got the ampulla, which is the widest and longest part, and that's where fertilization occurs. So if you get a question asking which part of the uterine tubes, probably the ampulla. And the other thing they can ask regarding that is about where along the uterine tubes does fertilization mostly happen, and it's in the lateral third, okay? Lateral third, or between the lateral third and median 2/3 kind of thing at that point. Isthmus, the next closest part, and then the intramural part, which is literally just I think it's half a centimeter, it's really, really tiny, and it's just the bit that's through the uterus wall. Arteries, there, and innervation there as well. This picture, okay, this is a good picture, very good picture.
When you said the uterine tubes thing with the lateral third, what did you mean in the lateral third?
Oh yeah, sorry. So say this is the thing. So this is say this is the point between the medial 2/3 and the lateral third. So that point there. That's what I meant. Does that make sense? Cool, good question. Yep, and here's just a label of the 4 parts. Any other questions, by the way? I haven't stopped once to ask if anyone's got questions. I don't know an awful lot, so if you ask a question I don't know the answer, I'll look it up for you and probably message you back. Okay, has nobody got any questions? Cool, all right. Female genitalia, uterus. Yep, so it's all here. They've got kind of 4 parts to the uterus: body, fundus, isthmus, and cervix. So just looking back on this picture, fundus, the body, isthmus, where's the isthmus? I can't even remember. Oh, there it is. Isthmus, and then the cervix. Yep. That's why I like this PowerPoint as well, because I put on as many pictures as I can, so you can actually see where things are. Ligaments, these are annoying to learn, and they're best learnt when you actually know what you're looking for. So you've got this thing called the broad ligament, which is actually composed of kind of 3 bits. So you've got the mesosalpinx, and salpinx apparently means fallopian tubes or something along that line. So it's the ones that, it's the broad part that's near the fallopian tubes. Mesovarium, near the ovaries. Mesometrium is near the uterus. The suspensory ligament of the ovary, round ligament of the uterus, and cardinal. I'll show you where all these are in the next one. And your vagina is the canal for menstrual fluid. So it's behind the urethral. So you've got the urethra, the vagina, and then your rectus in a female. That's 3 holes. Here are all your ligaments. I've just put in red square around them. So suspensory ligament of the ovary. It connects up the ovary, because the ovary is not actually connected to these, what do they call them? Fimbriae. Yeah, very good. Fimbriae. It's just kind of hanging in there, and it's suspended by the suspensory ligament of the ovary. And these are the 3 parts of the broad ligament that I was talking about: the mesosalpinx, mesovarium, and mesometrium. So yep, they're next to the fallopian tubes, ovary, and uterus, respectively. Ovarian ligament is this bit that connects. It doesn't actually, it's not a tube, it just connects the ovary up to the uterus as well. And just fun fact, you've got your little uterine vessels kind of floating about here. Yeah, it's a really good picture, this one. Lateral cervix or cardinal ligament is kind of further down. And yeah, round ligament of the uterus, I think ties the uterus to, I don't know what it ties it to, sorry. Yeah, it's there. Clinical things. Uterine prolapse. So this is like, you know, you had rectal prolapse where stuff can go out the back end. This is when things go out the front end. So not nice. You've got first, second, and third degree, which just get worse and worse. And I guess a question they can also ask is to do with like, what's the orientation of the uterus, which is a really dumb question because it like apparently changes quite a bit. But the textbook answer is anteverted and anteflexed, which means it's like leaning back a little bit and it's bending, so it's slightly flexed. So if there's excessive anteflexion, or if it's retroverted or retroflexed or whatever, that's abnormal. And anesthesia and childbirth, another thing they can probably ask you on. So there's kind of 3 options. You can do spinal anesthesia, so that's L3, L4, pudendal nerve block, S2 to S4, and caudal epidural, S2 to S4 as well. Alrighty. A woman is getting a hysterectomy. Which vessels near the supravaginal part of the uterus needs to be ligated? Sorry, I don't know why it's on a separate bullet point. Yeah. Anybody got any ideas? Yeah, somebody said uterine. And okay, the way that I would justify this, I think I say it in the next slide, but like vaginal is going to be too far down because we're talking about the supravaginal part of the uterus. Ovarian is going to be too high up because it's going to be near the top of the uterus. Uterine artery, if you look back, I think I put the picture here. Oh, I did too. Look at me. Okay, so yeah, the uterine vessels are right here. Like they're right next to that supravaginal part. So they're in the right place. Middle rectal and supravesicular artery. Well, middle rectal is too far back. Supravesicular is too far forwards because it's to do with the bladder. Cool? Does that make sense? Can you like slowly kind of get to picture where things are inside the pelvis? Lymphatics, again, this is like another way of looking at lymphatics, which is the organs and what nodes each organ drains to. So you can read that in your own time. Another picture of it. Another question. Okay, cool. Testicular tumor, lymph. Oh, sorry, I probably should have dwelled on the other side for a bit longer, but this is better. Lymph drainage is to which lymph nodes? So your testes. I think I've got way too many C's on this thing. Well, that's okay. Yeah, the answer is C, the para-aortic lymph node. So it goes straight up to, there. And that's different to your scrotum, which is the superficial inguinal nodes. Sorry, going through. Perineum. Okay, this is the last part of the talk, so just pay attention for probably like, hopefully 20 more minutes, maybe. maybe not even that. I'm just giving myself some time. So with the perineum, it's kind of like you've got the pelvis, and underneath it is the perineum. So yeah. And they show this like triangle-y thing here. So you've got the urogenital triangle, which is where your bladder and the urethra go through, and the anal triangle is where the anus goes through, and it makes this nice diamond-shaped thing. And there is it there as well. And this is, again, like looking at the pelvic outlet, because now you're looking at the bottom part. This is like the layers, and I think the important things to remember from this slide is the things that they're connected to. So Camper's fascia, does anyone remember, like, is that, because in your abdomen you've got Camper's, and okay, this kind of gives it away, but whatever. The Camper's one is more superficial to the Scarpa's fascia, yeah, so it's good to know what each of these connects with, because they can ask you that as well. This picture, I think, I never understood when they talked about the deep perineal space, superficial perineal pouch or whatever. There are two things that get kind of tossed around a bit. These pictures are probably the best thing I could find to help explain what all that is. So the deep perineal pouch is literally just the pouch that's around, it goes, they say, from the perineal, it's in the next slide. I'll do this first. So it's between your perineal fascia and the perineal membrane. So perineal fascia, where is that? Perineal fascia is, oh, hang on, no, that's the female's one. I'm sorry, I think it's here somewhere. Perineal fascia. One of these lines is the perineal, oh, there we go. Perineal membrane is the bottom one, perineal fascia is on top. Yeah. And the superficial pouch is the one that's like just underneath that, so it goes further down. And they also talk about this thing called the urogenital diaphragm, which is just the deep perineal pouch plus those two like fascial membranes. Okay. these are some canals that are just mentioned occasionally, so if you're interested in knowing where they are, you've got pudendal canal with the pudendal vessels, you've got what were the other ones I talked about? Ischioanal fossa. Ischioanal fossa is here somewhere in this fat, and your anal canal, which is obviously where the rectus goes out, you poop. Clinical things, this is just when you get weakness of your pelvic floor, so all those muscles, and that can be from like pregnancy to trauma, inflammation or infection. It can lead to these 3 complications, which are like, first one's called cystocele, so that's when your bladder kind of like falls through the floor and like crushes the uterus a little bit. So you get this like problem here. Rectocele, where the same thing happens with the rectum, and enterocele, which is where I actually get a bit of bowel that somehow falls into the pelvic cavity and pushes the uterus. The other thing is when mothers are giving birth, and if there's not a big enough hole at the bottom for the baby to come out, it's actually better for them to make a little incision rather than the baby like tear that stuff apart. So it's called epistomy, or epistomy, I don't know. That's what that is. And urethral rupture, oops, sorry, it's being covered a bit by that. It's common in pelvic fractures, and your spongy urethra in males is the like most a danger bit. Okay, male urogenital triangle, scrotum and penis. I'm sorry, I don't think I need to really go through this because it's all a lot of words, but I'll go through what's important in each of these slides. So point and shoot, I don't know if you've heard about this, but this is kind of, I think, my interpretation of like Helena's stuff in a nutshell. So point is for parasympathetic, and it's like erection. So it's parasympathetic, S2 to S4, and they're called your cavernous nerves. And I guess the way it works is that you have, I think it's in the next slide, in your penis you have these 2 things called the corpora cavernosa and one thing called the corpus spongiosum. And normally they've got blood vessels going through them and blood vessels kind of around them as well. And normally you have anastomoses, so connections between all those vessels. So when blood goes, it's distributed evenly between all those things. Whereas when you have an erection, those external vessels, they're kind of shut off. So all the blood suddenly goes through the vessels in these ones, so the corpus cavernosa and corpus spongiosum. So you get like blood filling these main muscles, and so you get an erection. Okay, that's what that says in words. And ejaculation is sympathetic, so L1 and L2. So it's quite different things. Yep. That was that. And the scrotum, just in case you wanted to see like anatomically what it is. Females, yeah, this is not my favorite bit. It's just like, it's basically just stuff you have to learn. So there's kind of these aspects to it, the mons pubis, and to be completely honest with you, this is not worth learning. You're never going to be asked on this, anything on this, but I've put it in here if you want, with a picture there, yay, and then a question. A woman is just diagnosed with PCOS. Does anyone know what PCOS is? Yeah, polycystic ovarian syndrome. After presenting to her GP with scanty intermittent periods, what other symptom is she most likely to also complain of? Yeah, hirsutism. That's just another like buzzword I think that you've got to remember. PCOS is associated with hirsutism, which is when you get hair, like when you just become really hairy. Yeah, so I don't know if any of you are doing, is it an SPC topic? Are you guys doing SPC? No? PBL? No? Done it? Cool, yep, cool. Was PCOS one of the topics? I'm not sure. Oh, it's been changed. Okay, it was one of our topics, so yeah. Histology. So I didn't know I was doing this till very last minute, so I chucked in a lot of pictures. But yeah, this is important to know because when they give you histology questions, it won't just be one more point. It'll be like 5 points that relate to the same picture. So it's good to know your histology, just for a med exam. So yeah, here are your structures. So you've got the epididymis, and inside you have all these seminiferous tubules. And if you take a cross-section of that seminiferous tubule, you've got, this is what you have. And this is like a zoomed out picture of a seminiferous tubule with this interstitial space going between it. And in that interstitial space, you have Leydig cells. Important. And Leydig cells are the ones that produce testosterone. And testosterone then diffuses into the seminiferous tubules and feeds the sperm. So that's a really beautiful picture. What it mostly actually looks like is this. So that is actually also a seminiferous tubule that is not circular, but that's what it is. And your Leydig cells are in between these circular blobs. And then the other thing that you need to know is the order that sperm mature. So you've got spermatogonium to spermatocyte to round spermatid to elongated sperm. And it goes from the outside to the inside. And then the sperm kind of learn how to swim, and then they get flushed down the tubule kind of thing into the epididymis. That's the way I think of it anyway. So yeah, remember that. Spermatogonium, spermatocyte, round spermatid, and elongated sperm. And there's one more cell type that you need to know, which is this Sertoli cell. I've got a question at the end. And they call them teardrop-like cells. And I think they're fairly obvious to spot. Like I think, oh, here we go. Here's a picture of one here. So it just looks quite different to all the cells around it. So that's a Sertoli cell. So I expect you guys to get 100% on histology. You can easily learn this stuff, and it's high yield. Okay. Sertoli cells have these different functions. So they help determine sex. So if you have this SRY gene expressed, you're going to be a male. They have AMH if you're a female, no AMH if you're a male, and then it disappears after that. Hormone regulation, so they help regulate FSH levels. Stem cells, this is GDNF, and it helps form the blood-testis barrier for protection. Yeah, there's about 500 of these tubules per testis, and we've talked about Leydig cells and that they produce testosterone. Something that I think was mentioned in one of your lectures, well, it was mentioned in one of ours, was this cryptorchidism, which is just when you have an undescended testis. So, yeah, it just looks something like that, and most of them are kind of just superior to the scrotum, so this hasn't quite descended yet. And funnily enough, 5% of newborn males have an undescended testis, but it usually by around 9 months descends. So yeah, but if it doesn't, it's quite dangerous because it's obviously a lot warmer in your body. The reason why you have your testes down there is because it's cooler. So you can kill the sperm, and there's a high chance of developing tumours. And obviously, because you only have one testis, if something happens to that testis, it's not fun. Histology for... Oh, any questions about any of that? Anyone confused about any of these cell types? The Leydig, anything in the sperm progression? No? Okay, good. Sertoli cells. Females, I'm not going to talk about the ovarian, the cycle, but unfortunately I have to talk about the stages of, so in your ovaries, once they've released, when the ovum, the egg is there, the formation of that whole process, and then once the egg's released, what it all looks like, because you can get asked on that too. So pictures for you. So it starts off with these primordial follicles, which just have one cell membrane around them. Then it goes to primary, where those flat cells become cuboidal cells. Then you get these secondary things where it's you get multiple layers. And then when you start going into antral follicles, so it's primordial, it's kind of pre-primary, then primary, secondary. Antral means you have this antrum, kind of nice and self-explanatory, which is just this fluid stuff that's there. And that gets bigger and bigger until you have this it's not actually in this picture, but it's called a Graafian follicle. And while all of this is happening, you kind of still have your ovum in here, so your little egg, with its 2 layers of cuboidal cells. Yep, that's about all I have to say. And this picture here is a picture of the oocyte. So it's here, and the oocyte has its own little the cuboidal. It's called a corona radiata cells around it. And zona pellucida, that's another word that you might hear. That's what, so when the egg is released like this, and if it gets fertilized by a sperm, the sperm has to dig its way through these cuboidal cells and past the zona pellucida. Okay? So corona radiata is the name of that protective barrier of cells, and the zona pellucida is just inside that, and that's what the sperm has to get through. And these are just pictures from the histology lectures that I had, I presume you had as well. So it just shows primordial, primary to secondary, you just have more layers. So primordial, you can kind of, it's just literally that is the ovum, and you have this tiny layer of cells around it. and then you get more layers, and then you get like an antrum forming. So here's your little antrum. So this is like a really zoomed up picture, okay, just to put it into perspective. So that's your little ovum. This is all the layers of like cuboidal cells and your tiny bit of antrum. So this isn't even the full, like the full one would be like that big. Cool? And then Graafian follicle is like, this is the whole thing. So that's how much fluid is there, and that's your tiny little ovum. Does that make sense? So if you were shown one of those pictures, you reckon you could say, yep? And I was feeling really tired at this point, so there's like, if you have pregnancy, or regardless of whether you have pregnancy or not, you form this thing called a corpus luteum, and it's like this fluffy white cell thing, and it produces progesterone in like hope that if you're going to have this baby, it's going to keep the uterus walls nice and thick for you so the baby gets some nutrition. If there's no pregnancy, that corpus luteum dies after 10 to 14 days, and you're left with this white scar. And I just saw a scar, and I was like, Harry Potter. So I put Harry Potter. It doesn't make any sense, I'm sorry. But yeah, corpus albicans is what that scar is what it's called before it becomes a scar. If there is pregnancy, you get this secretion of this hormone called HCG from your placenta, and that develops, or it stimulates the corpus luteum to keep secreting progesterone for like 6 months. And then it eventually becomes a white scar also. So again, Harry Potter. Yeah, okay. What is the function of Leydig cells? Androgens, very good. So androgens, testosterone is an androgen. Good. What is the best, what best describes the main function of progesterone in the menstrual cycle? B, I heard? Yes, very good. So it's like here you can cancel out C and D, because C is to cause, like the spike causes ovulation, that's to do with LH, and to suppress LH secretion, that's just wrong. Promote growth in the endometrium, in the follicular phase, it actually promotes growth in the secretory phase, just random fact, okay? So the follicular phase, it's in this diagram somewhere, oh there you go. Follicular phase is this first part, luteal phase is the second part. Cool? One more question. We're coming to the end. Sorry. Sorry to keep you here so long. What makes the blood-testis barrier? This has to do with one of the... if I tell you, it's going to give the answer away. Never mind. Yeah, A. So one of the functions of the Sertoli cells was to help protect the sperm by like maintaining this blood-testis barrier. So yeah, Sertoli cells. Important. Okay, these questions... Do you want to do more questions? These are the last bits of my thing. Do you want to go through them now quickly? There's like, it's just a label identifying task. So what is the endocrine part of the testis? First of all, what is it? That's a really bad thing. The answer is E, and the answer is the Leydig cells, because they produce testosterone. I'm so sorry. That should, I might change the wording of that. That's just what I copied and pasted. The most primitive part that replicates through mitosis. Which of these do you think that is? Yep, A, spermatogonium. Very good. Next question, the supportive cells. Can you see any cells, probably best in this picture, that look like diamonds?
C.
Yeah, C, kind of looks like a diamond. So yeah, C. They don't really look like diamonds here, but here they do. So C is your Sertoli cell, and the last one, cells that are formed from meiosis II. D. Yeah, very good. So they're your like sperm. Okay, that is the end. Thank you all very, very much for paying attention. Thanks for coming. Any last minute questions or anything? Great. I'll stay here for like 5 minutes if anyone wants to ask anything.